Number one is smoking cigarettes or any sort of long-term tobacco abuse. I think we're finding that there is some element of genetic play, that not everyone that smokes obviously develops these aneurysms, but the big concern is for the majority of aneurysms in your body is rupture. So recognizing these early and treating them early has proven long-term that it's certainly saving lives and preventing these ruptures. Scarily, they're silent. If you've got a CT scan or an ultrasound for some other purpose and it was incidentally found, then that could lead to it. But these are typically not symptomatic until there's a problem. Treatment options are both open and endovascular. Open treatment is a large incision in your abdomen to open it, take out the aneurysmal portion. Endovascular treatments in the last 10 years taken over as treatment of choice, but again, just through small poke holes into the arteries in your groin and we can seal off the whole thing. Using the open technique, basically no, as I said, you take out the aneurysm and it's a woven plastic polymer that we put in there. So from that standpoint, that does not become aneurysmal itself. With the graft, yes, that's why you have to continue to monitor and surveil these, because the aneurysm can continue to grow if there's a small leak. We call them endo leaks. They get around the graft. So you have to keep an eye on that, because some will, and if you don't, then the patient's just as much risk as they were prior to you even intervening. So you have to keep a close eye on those. Anyone that's over the age of 60, it is approved for screening. If you've had any sort of smoking history, you should get screened and talk to your primary care physician about screening for abdominal aneurysms. The screening is an ultrasound, it's non-invasive. The issue is catch them earlier. The larger they get, the higher the risk of rupture.